Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We'll have Emma Seals presenting, who is a P4 pharmacy student at The Ohio State University. She'll be presenting on bleeding risk with Apixaban versus Rivaroxaban in acute venous thromboembolism, or the COBRRA trial.
Here are a list of abbreviations that I will frequently be using throughout the presentation. The objectives of this presentation are to describe the key literature published prior to the COBRRA trial, evaluate the study design and results of the COBRRA trial, and discuss the implications of the COBRRA trial on clinical practice. First, to give background into the statistics surrounding VTE, it is the third most common cause of acute cardiovascular events and death worldwide. There are up to 900,000 people in the United States who are affected by VTE annually. Out of these 900,000 people annually, approximately 60,000 to 100,000 Americans die from VTE each year. And these VTE events contribute to approximately 652,000 and 394,000 ED visits for DVT and PE over a 5-year period. Due to the prevalence of VTE events, next we will discuss guideline recommendations for VTE management. The CHEST guidelines currently provide guidance for the duration and drug of choice for VTE treatment. For patients with VTE without a cancer diagnosis, DOACs such as dabigatran, Rivaroxaban, Apixaban, or Indoxaban are recommended over VKAs for acute VTE treatment. When determining the appropriate duration of anticoagulation therapy, it's important to assess for the presence of risk factors and absence of major or minor transient risk factors due to the guide treatment duration. For patients with acute VTE, a 3-month treatment duration of anticoagulation is recommended. However, the guidelines do not recommend one DOAC over another. While the CHEST guidelines are specific to VTE, the AHA and ACC guidelines are specific to PE anticoagulant recommendations that we will discuss next. So when looking specifically at the AHA and ACC PE guidelines, they also recommend DOACs over VKAs to prevent recurrent VTE and reduce major bleeding in patients with an acute PE. However, they also do not recommend a specific DOAC over one another. Now we will look into the previous literature that supports the use of DOACs over VKA like the guidelines have recommended. When first discussing the AMPLIFY trial, we will evaluate patients that had acute symptomatic VTE, which could have been either a DVT or a PE. Patients were then split into 2 groups to receive either Apixaban dosed at 10 milligrams twice a day for 7 days, followed by 5 milligrams twice a day. They compared this to conventional therapy of enoxaparin dosed at 1 mg per kg every 12 hours, with warfarin adjusted to a therapeutic INR goal of 2 to 3. Both groups were evaluated for over 6 months. In this trial, they found that Apixaban was non-inferior to a conventional therapy. They also evaluated major or clinically relevant non-major bleeding in both groups and found that Apixaban had a lower bleeding risk at 4.3% compared to the conventional therapy group at 9.7%. These results support the CHEST and AHA-ACC guidelines in recommending a DOAC over VKA therapy. Now we will evaluate more trials looking at Rivaroxaban compared to VKA therapy. The Einstein trials were separated into PE and DVT trials separately. First, we'll talk about the Einstein PE trial, which included acute symptomatic PE that was with or without a DVT. It included 2 randomized groups. One group received Rivaroxaban dosed at 15 milligrams twice a day for 21 days, followed by 20 milligrams daily. This was then compared to the standard of therapy group of enoxaparin dosed at 1 mg per kg every 12 hours for greater than or over 5 days, in addition to warfarin, which was adjusted to a therapeutic INR of 2 to 3. They found that Rivaroxaban was non-inferior to standard therapy for VTE recurrence. When looking at major or clinically relevant non-major bleeding, Rivaroxaban had a lower bleeding risk at 10.3% compared to the standard of therapy at 11.4%. Next, when evaluating the Einstein DVT trial, they looked at patients who had acute symptomatic DVT that was either with or without a PE. They randomized patients into 2 groups, either to receive Rivaroxaban dosed at 15 milligrams twice a day for 21 days, followed by 20 milligrams daily. This was compared to the standard of therapy of enoxaparin 1 mg per kg every 12 hours for greater than or equal 5 days, in addition to warfarin adjusted to a therapeutic INR of 2 to 3. They also looked at patients for 3, 6, and 12 months, which was longer than any other trials had evaluated in relation to duration of time. The results of this study showed that Rivaroxaban was non-inferior to standard therapy for VTE recurrence. However, it did show that there was no difference between major or clinically relevant non-major bleeding between both groups at 8.1%, which was different than the Einstein PE trial that showed lower bleeding with Rivaroxaban. However, when compared with the Amplify trial, the bleeding risk was lower with Apixaban. And when looking at the trials, it has just been hypothesized that due to the differences in trials and patient populations, they were unable to correlate whether Apixaban was the lower bleeding risk versus Rivaroxaban. So overall, even though these trials showed superiority over warfarin, how do Apixaban and Rivaroxaban compare head-to-head with bleeding risk? So now that we have evaluated previous literature and understand the basis for the COBRRA trial, we will discuss the trial in detail. When looking at the study design, it was a pragmatic international trial with a prospective randomized open-label blinded endpoint or probe design. It was completed between December of 2017 to January of 2025 across 32 centers in Canada, Australia, and Ireland. For the primary outcome, they looked at clinically relevant bleeding, which was a composite of major bleeding, which was defined as fatal bleeding, symptomatic bleeding in a critical area or organ, and then bleeding that caused a fall in hemoglobin level of over 2 grams per liter, or that was leading to a blood transfusion in over 2 units of either whole blood or red cells. They also included the composite of clinically relevant non-major bleeding, which was defined according to the International Society on Thrombosis and Hemostasis. When evaluating the secondary outcomes, it was individual components of the primary outcome. They looked at recurrent symptomatic VTE, which included both DVT and PE, and they looked at death from bleeding, death from recurrent VTE, or death from any cause, which was confirmed on autopsy reports or findings on the death certificate. And then they also evaluated medication adherence at the follow-up visit, which was assessed based on a questionnaire given to all patients. For patient randomization, initially 9,753 patients were assessed for eligibility, but due to exclusion criteria and declining to participate, 2,760 patients underwent randomization. Patients were then randomly assigned 1-to-1 to receive Apixaban or Rivaroxaban. 1,370 patients were assigned to receive Apixaban, but 25 patients were excluded due to either death, loss of follow-up, withdrawing consent, or not completing the trial, for a total of 1,345 patients included in the primary outcome analysis. Then 1,390 patients were assigned to receive Rivaroxaban, but 35 patients were excluded due to death, loss of follow-up, withdrawing consent, or not completing the trial, for 1,355 patients including in the primary outcome analysis. For the inclusion and exclusion criteria, to be included in this trial, you had to be over 18 years old, have symptomatic acute VTE, and provide informed consent. For the exclusion criteria, patients were excluded if they received over 72 hours of therapeutic anticoagulation before enrollment, if their creatinine clearance was less than 30 mLs per minute, that was calculated with the Cockcroft-Gault equation, or if they had a known liver disease. If the patient had any contraindication for anticoagulation with Apixaban or Rivaroxaban that was determined by the treating physician, they were excluded. If they had any active bleeding at the time, if they had active cancer, which the study defined as diagnosed with cancer within the past 6 months, recurrent or regionally advanced metastatic disease, currently receiving cancer treatment or have received cancer treatment in the past 6 months prior to randomization, and then finally, if the patient had a hematological malignancy that was not in complete remission. And then they excluded patients who had a weight exceeding 120 kilograms, since DOACs have not been studied in the extremes of weight. And then they excluded any patients who were on contraindicated medications at the time, or if the patient had another indication for long-term anticoagulation, such as atrial fibrillation, or if the patient had a mechanical heart valve. And then finally, they excluded patients who were pregnant or breastfeeding. For the intervention groups, patients were randomly assigned in a 1-to-1 ratio to receive Apixaban that was dosed at 10 milligrams twice a day for 7 days, followed by 5 milligrams twice a day, and Rivaroxaban that was dosed at 15 milligrams twice a day for 21 days, that was then followed by 20 milligrams daily. And the patients in both groups received treatment for 3 months. And the study dosing regimen is based on the VTE guidelines and aligns with dosing that has been done in previous trials. For the methods of this study, a treating physician used an approved script to provide all pertinent information to the patient, and the patient then provided oral consent to undergo randomization for 3 months. Data was collected at the trial sites and entered into an online database. Patients were randomized via a centralized web-based system and permuted block design with stratification according to renal insufficiency, which was classified as a creatinine clearance less than 50 mLs per minute or over 50 mLs per minute. They also evaluated continued antiplatelet use, since this can increase the patient's risk of bleeding, and the participating center. Clinicians and patients were both aware of the treatment. Patients also received local prescriptions for the assigned medication that was sent to be filled at their local pharmacy. However, the trial is unclear whether the patients had to pay for the medication themselves. There were 7 patients who did not receive Apixaban and 8 patients who did not receive Rivaroxaban. However, the trial is unclear as to why they did not receive it, whether it was due to cost or not the pharmacy not having the medication. So unclear, but there were patients that did not receive it. And then trial visits were scheduled at enrollments, 2 weeks plus or minus 1 week, and then 3 months after randomization. And then after the 3 months, an independent committee member who was unaware of the treatment reviewed all suspected outcome events and cause of death. When looking at the statistical analysis for this study, they used 80% power to detect a 33% difference in clinically relevant bleeding at two-sided alpha of 0.05. The expected primary outcome was 5.4% with Apixaban versus 8.1% with Rivaroxaban. Based on the previous trials of Amplify and the Einstein trials, they had found a 1% loss of follow-up. So for the COBRRA trial, they plan to be conservative and have a 2% loss of follow-up. So they plan to have 1,352 patients per group, and they plan to enroll 1,380 patients per group to plan for this loss of follow-up. The primary outcome was analyzed in the intention to treat population, and they used a chi-square test to calculate the unadjusted odds ratio and 95% confidence interval. The Kaplan-Meier method was used to look at the time to event analysis for bleeding, and the sensitivity analysis was used to look at the mixed effects logistics regression adjusted for stratification variables. And then finally, the secondary outcomes were completed using a unadjusted odds ratio and 95% confidence interval. When looking at the baseline characteristics for these patients, there were a few I wanted to highlight. First, when looking at the age for these patients between the two groups, it was approximately 58 years old, which correlates with many of our older adults being on anticoagulation. Then, since renal function was one of the stratification variables with being less than 50 mLs per minute or over 50 mLs per minute, I wanted to highlight how they look at overall creatinine clearance and less than 50. The average overall creatinine clearance was approximately 106 mLs per minute between both groups, with approximately 4.5% of patients who had a creatinine clearance less than 50. Also, the number of patients who were continued on antiplatelets was both in same groups, therefore eliminating the bias of whether the antiplatelet therapy being continued was contributing to increased bleeding risk in a specific group. Then, when looking at the VTE events, DVT alone was the most common in these patients, with an unprovoked VTE occurring in approximately 77% of patients. Finally, the history of VTE is high in both groups. While the study didn't specifically say why, I hypothesized that it might have been patients who had a history of a provoked VTE and then completed 3 months of therapy on anticoagulation and then had it discontinued after completion of therapy. Now, when looking at the results of this study, the results overall favored Apixaban. When looking at the primary outcome of clinically relevant bleeding, Apixaban was lower at 3.3% compared to Rivaroxaban at 7.1%, with a p-value of 0.001. When evaluating the secondary outcomes, major bleeding occurred in 5 patients in the Apixaban group, which was indicated by a decrease in hemoglobin of over 2 or a blood transfusion, which occurred in all 5 patients. In the Rivaroxaban group, there was a total of 32 patients who had major bleeding, with 28 of those patients having a decrease in hemoglobin level or a blood transfusion, and then 4 of those patients had bleeding in a critical area or organ. Then, clinically relevant non-major bleeding occurred in 2.9% of the Apixaban group, with the most common areas being vaginal bleeding, occurring at 2.7%, and GI bleeding occurring at 0.6%. In the Rivaroxaban group, 4.9% had clinically relevant non-major bleeding, with vaginal bleeding occurring in 3.8%, hematuria in 1.3%, and GI bleeding in 1% of patients. Comparing these values to previous trials, the incidence of vaginal bleeding with Apixaban was lower in the COBRRA trial than it was in the AMPLIFY trial, which found 5.4% of vaginal bleeding. And the incidence of vaginal bleeding with Rivaroxaban was also lower in the COBRRA trial than that was seen in the Einstein trial at 9.5%. Another thing I wanted to highlight is looking at the adherence at 3 months. The Apixaban group had approximately a 10% lower adherence than Rivaroxaban. This is probably contributing since Apixaban is dosed twice daily versus Rivaroxaban being dosed once daily. However, the risk of the recurrent symptomatic VTE was the same in both groups at approximately 1%, indicating that the lower adherence did not impact efficacy. Finally, the number needed to harm was 26 patients, indicating that treating 26 patients with Rivaroxaban instead of Apixaban led to an additional 1 clinically relevant bleeding event. I also wanted to include the Kaplan-Meier curve. So the time to event analysis was conducted with the Kaplan-Meier method to show the probability that a patient remains bleeding-free as time progresses. It looked at the primary outcome of clinically relevant bleeding during the 3-month treatment period. This figure shows how patients on Rivaroxaban had a bleeding event that significantly increased up to day 21. This correlates with the loading dose of Rivaroxaban, and when comparing the loading dose between the two DOACs, patients on Rivaroxaban are on loading doses 14 days longer than patients on Apixaban, which could be contributing to the increased bleeding with Rivaroxaban in the first 21 days. For the strengths and limitations of the study, some strengths of it included that it was a prospective randomized design with a large sample size. It also included a very clinically relevant primary outcome, and it was the first direct comparison between Apixaban and Rivaroxaban study that has been completed that eliminates confounding bias and provides high-quality comparative effects. Also, the dosing regimens match those that are used in clinical practice, so those dosing can be extrapolated to what we use today. And then finally, especially with patients who have provoked VTEs, this trial assessed the period of highest risk during VTE treatment with the 3-month treatment phase. When looking at limitations, it was an open label design, so it did have a potential source of assertment bias. It also does not evaluate long-term bleeding risk, so it is unsure if the bleeding risk plateaus after the 3-month period. I personally would have liked to see a longer follow-up with these patients, especially since a lot of our patients are on lifelong anticoagulation with DOACs. It also excluded patients that were over 120 kilograms with cancer-related thrombosis. It also did not look at the differences in loading dose duration and the dosing frequency, especially since Rivaroxaban has 14 days of longer loading doses, which can potentially increase bleeding risk. It also did not specifically state if patients were taking Rivaroxaban with food, since this could impact absorption if they were taking it on an empty stomach and could potentially underestimate the bleeding risk associated with Rivaroxaban. And then finally, another limitation is that it was not powered to detect differences in the risk of recurrent VTE. For the author's conclusions of this trial, the risk of clinically relevant bleeding in patients with Apixaban or of acute VTE was significantly lower with Apixaban during the 3-month treatment period. However, the trial doesn't explain the differences in bleeding risk between Apixaban and Rivaroxaban. And it is hypothesized that the higher bleeding risk with Rivaroxaban may be related to its higher loading dose compared to the maintenance dose, especially since patients on Rivaroxaban are on a longer loading dose compared to Apixaban. But now that we have evaluated the COBRRA trial, how does this compare to clinical practice, especially in the emergency department? There are many patients who present to the ED with a new diagnosis of VTE, and some patients are discharged on a new DOAC. So what are the considerations when choosing a DOAC for a patient? So first I'll talk about when to consider Apixaban. So when you do not have any adherence concerns for your patient, especially since this is dosed as a twice daily medication, if there is no insurance limitations or access issues, with Apixaban, there are copay cards available. I know the medication can be pretty expensive, but there are ways, especially through the manufacturer, to get the Apixaban. And then as this trial has shown, if patients are at higher bleeding risk, it should be appropriate to use Apixaban since it has a lower bleeding risk compared to Rivaroxaban. And then with renal impairment, also consider Apixaban compared to Rivaroxaban. And then, as mentioned earlier, since Rivaroxaban must be taken with food, if patients have inconsistent food access and don't know if they'll be able to have a full meal every day, Apixaban is the best medication compared to Rivaroxaban, so that way their impact of the DOAC is not being messed up. And then finally, with allergy, intolerance, and therapeutic failure with Rivaroxaban, you can trial Apixaban. And then when to consider Rivaroxaban, if there's any adherence concerns, since this medication is dosed once a day compared to twice a day with Apixaban, or if there's any insurance limitations or access issues with Apixaban, and then any allergy intolerance or therapeutic failure with Apixaban, you can trial Rivaroxaban. However, there are considerations with both DOACs, so it's always important to check for drug-drug interactions for these patients, since there are significant drug interactions, and then always be mindful if your patient has any hepatic impairment as well. When looking at the key takeaways from this presentation, overall, Apixaban is associated with a lower bleeding risk than Rivaroxaban. However, patient-specific factors should always be considered when selecting a DOAC, since one preference can choose either Apixaban or Rivaroxaban based on the patient. And then finally, data should not be extrapolated to obese patients or patients with cancer-related thrombosis. And then here are my references.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.